we will get started. Today, we get to put together some information that we have learned thus far. We're going to actually talk about some rhythms. We're going to specifically focus on tachyarrhythmias today. So how I want you to approach this is you're looking at an ECG. And on that ECG, you look at that bottom 10-second rhythm strip. When you look at that 10-second rhythm strip, you say, let me see what this rate is. And the rate is greater than what? 100. The rate is greater than 100. These are the differentials that I want you to put in your mind when the rate is greater than 100. Now, is this 100% all-inclusive? No. Because we don't have time for all that. So this is the majority of the things that you're going to see that's going to cause a fast heart rate. Okay? Some that we can manage, pretty easily, and others we need to manage pretty quickly, or the patient's probably not going to survive. So there are ELOs and our TLOs. Let's do a little bit of review. Hair, Jamie Hare. Okay, ma'am. 6-second and 10-second method is going to calculate, we're going to use that to calculate what type of heart rhythm. Or so think about we use our counting method. Use counting method. What type of rhythm must you have to use for the counting method? Must be regular. We can use we can't use a counting method for irregular because it depends on where you start in their irregular rhythm. Well, we kind of what your rate is. And so we use this for irregular. Can we use it for, let's say, normal 10-second strip? Sure, you can use it for that too. But you cannot use the counting method for irregular rhythms. Because if the first 2 beats are this far apart, and the next 2 beats are this far apart, when you're counting, depending on where you start, and depending on what your rate's going to be, so you cannot use it. So 6 and 10 seconds can be used any time, but they must be used for irregular. Cannot use a counting method for irregular. So we've got our irregular rhythms. Okay, Keen, tell me what is the rate that you're seeing on this rhythm strip?
Echo, ma'am.
Echo. Okay, and how did you get that? You counted all the things. Okay, good. Can we use the counting method on this? Oh, that was way too long, sorry. We can use the counting method, right? Sure. We find an R that's that appears to be on a dark line, which is pretty easy to tell them, and we can count over. So if we use the counting method, what might our rate be? So just under 300, right? Just under 300. Well, there's a big difference between 250 and 300. Right? When we think about numbers-wise, but we think about management-wise, there's not much of a difference. We're still going to manage those patients about the same, right? We think about presentation-wise. I mean, if you got a heart rate of 250, you're probably not going to be feeling great. If you got a heart rate of 300, you're also probably not going to be feeling great, right? So our presentation is probably going to be very similar as well. So we can count all of the R rates. We've got 25 R rates. And what kind of strip is this? A 6-second strip, right? Because down here at the bottom, we've got a line here, we've got a line here, and we have a line here, which means we have 3 seconds here, 3 seconds here. It's a 6-second strip, so we times that number of R waves by 10. So 25 R waves times by 10, 250. And when it's this fast, although you can certainly use the counting method, Sometimes it's more accurate, a lot of times it's more accurate if you actually count the R waves and times it by that 6 or times by 10. We're going to continue on with our deliberate approach to reading these ECGs. We must have a deliberate approach to every single ECG you put your eyes on. You can't just look at that ECG and just be like, and not have an approach, because you're going to miss so many things in that ECG that are either going to impact that person today or impact them in several weeks or several months or several years from now that you could have caught today. So every single ECG, use your approach. We're going to look at that rate. Okay, we're going to look at that rhythm. After that, we'll talk about axis, hypertrophy, infarction. If you have an old ECG to compare it to, grab an old ECG to compare it to. Okay, look at how this patient is presenting to you as well. Because if you're like, I don't really know, this patient looks pretty ill, or they look pretty good, it's going to depend on what you're figuring out on this ECG. So we're going to focus on our rhythm. We're still in that part. And look at our intervals, our waves, and our segments. We're going to look at that rate. Is it fast or slow? We talk about tachyarrhythmias, we talk about fast rate. Bradyarrhythmias, we talk about a slow rate, and normal is going to be between 60 and 100. Is the rhythm regular or irregular? If it is irregular, is it regular irregular? Meaning I've got 2 beats, 2 QRS complexes, and then I've got a space. 2 QRS complexes, then a space. Well, it looks to be consistent. Even though it's irregular, it's consistent. Or is it, I got 1, I got a space, I got a really close one, I got a far one. Is it irregularly irregular? QRS complexes, are they wide or narrow? Okay. Do I have P waves that appear to be associated with my QRS complexes? So I should have P waves before my QRS complexes. Are those QRS complexes regular, or are they grouped together? And are there any drop beats? So I have a P without a QRS complex. We've got to then look at our ST segments. Are they elevated or depressed? That's what we want to know. P waves. Do we have P waves? Do all of the P waves look the same? Because if all the P waves look the same, this is coming from the same foci. Maybe it's yes, a no. Maybe it's an alternate foci in the atria, but the P waves look the same. It's coming from the same area in that atria. Does each QRS complex have a P? So we should have P's, then QRS's. If we don't, then something is blocking the depolarization between the atria and the ventricles. We're going to look at those T waves. They should be asymmetric. So we're going to determine if they're asymmetric or symmetric. Are they upright? Okay. Are they flat, so they're on baseline, or are they inverted? Okay. Those all mean something. Upright is normal. If they're flat or inverted, maybe we have a problem with our electrolytes that's causing this to occur. Maybe we have some ischemia that's causing this to occur. Don't forget about your intervals, PR interval. Is it normal, or is it prolonged, or is it short? Okay? Is it constant? Every PR interval should be the same if you go from one PQRS complex to the next. It should all be the same. So is it constant, or is it variable? Is it prolonged, or does it get longer and longer with each beat we're looking at? QT intervals, prolonged or shortened. We know that normal QT intervals, 350, 450 for males, 360, 460 for females, or we think about half of the R to R. That's all the things that you have to look at every single time that you're looking at the rhythm. Okay. Now, let's look at our tachyarrhythmias. We're going to separate these. Okay, we've got narrow and regular. When I say narrow, I mean the QRS complex is normal. Okay, narrow, and then my R to R is regular. And we got sinus tachycardia, we have supraventricular tachycardia. And technically, all of these are supraventricular, but in the cardiology world, we have specific rhythms that we talk about called SVT. And so we'll talk about that. And then with atrial flutter. So again, these are going to be narrow QRS complexes, but that R to R is going to be regular. So if you look, you identify on that 10-second strip at the bottom of your ECG that we have a tachycardic rate. You're going to look at that QRS complex and you say, narrow. Okay? I'm only thinking about these things. It's narrow and it's regular. These are my differentials. I can forget about all the rest of these differentials because they're not going to be in there. These are my differentials for narrow and regular. Okay? We have narrow, which is still that QRS complex, and we have irregular, meaning R to R does not march out normally. Okay, maybe it's a little closer for the next one. Maybe it's a little further away, but it's not regular. Atrial fibrillation will be our most common cause of irregular narrow complex tachycardia. We can also have a type of atrial flutter where the block is variable, and I'll talk about that more in a minute. And we can have something called multifocal atrial tachycardia. That's going to cause a narrow complex, but it's going to be irregular from R to R to R. We have wide and regular. So again, I'm going to look down at that 10-second strip. I'm going to determine, is my QRS complex wide or narrow? And if it's wide and it's regular, these are my differentials. Not very many of them. V-tach and V-flutter. Okay? If you had to choose, what would you rather have, V-tach or V-flutter? V-tach. Definitely. I definitely want V-tach. Way more than V-flutter. V-flutter very quickly turns into V-fib, and that very quickly turns into death. Okay, so V-tach. If you look and you have wide and then it's irregular from R to R, these are your differentials. V-fib, polymorphic V-tach, and torsades de Pointes. So let's start with our narrow and regular. That's a sinus tachycardia, our SVTs, and then our atrial flutter with a non-variable block. How might these patients present? Well, all these patients with tachycardia oftentimes present very similarly. They're weak, they're dizzy, they're having palpitations. I felt like I was going to pass out, or I did pass out. Maybe I have shortness of breath. A lot of times they're going to have exertional symptoms. I'm okay if I sit down, but when I go to stand up and walk around or do something, I get more and more short of breath. Sinus tachycardia. We think about sinus tachycardia, rates greater than 100, and typically not more than 150. Now, I saw a person last week that had the flu, healthy 22-year-old male, heart rate was 160. Okay? We did an EKG, and still a sinus tachycardia. But we think about 100 to 150. As we're going through these rates, do not memorize the rates. Okay? They're not because they're not set in stone. They can be outside of those parameters. But when we have heart rates of 160, 170, okay, we want to think, okay, now wait, is there something else that can be besides sinus tachycardia? So don't focus and hone in specifically. Well, it's 160 or it's 170, so it can't be sinus tach. That's not true. It could still be, but we want to make sure we expand our differential to make sure we're not missing something. So we've got this rate of greater than 100, usually around 100 to 150. R to R intervals are going to be regular. Okay, this is a narrow complex regular. Okay, and we're looking for those P waves. Because this is a sinus tachycardia, meaning it's coming from the SA node down to the AV node, down to the ventricle. So we should see PQRST. Our QRS complexes are just going to be really close together because this is a really fast heart rate. So on this ECG, we have an ECG of a sinus tachycardia. So if we look in lead 2, we can see upright P. If we look in AVR, we see a downgoing P, so that tells us coming from the SA node. And then if we look at our 10-second strip down at the bottom, we can see regular, R to R, but it'll look super fast, but we see PQRST, PQRST, PQRST. So this is a sinus tachycardia because we see P waves, either upright in 2, downgoing in AVR, and we have our QRST complex after that. A lot of things can cause sinus tachycardia. Oftentimes, fever, volume depletion, influenza, COVID. So viral syndromes can cause this. Certainly, if you go out and run a couple of miles, you take it and you put your hand on your pulse, you're probably going to be tachycardia, and it's probably going to be a sinus tachycardia. If someone is anemic, so let's say you have a person that's coming in and they say, I'm coming in for heavy menstrual cycles, and they are tachycardic. One of the differentials you need to have in there is maybe they're bleeding so much that they are anemic that's causing their tachycardia. Because a lot of women have heavy menstrual cycles, but they're not tachycardic. So anemia can be one of those things. Hypotension, if they're hypoxic. Okay, hypoxemia and tachycardia. What would be your number one differential for hypoxemia and tachycardia? Pulmonary embolism. Pulmonary embolism is going to be on there. okay? Thyrotoxicosis, which means your thyroid is hyper or hypo? Hyper, okay, so your TSH levels are going to be really low, but you're in a thyrotoxicosis, your thyroid is acting crazy. That can cause sinus tachycardia. And usually what we're going to see, if we have these patients on a monitor, we're going to see where the heart rate's 120, and then it's down 118, and then 122. So we're going to have kind of this fluctuation of this heart rate, okay, within a couple of beats. So that's it for sinus tachycardia. PQRST, look at your lead 2, look at your ABR, upright P and 2, downgoing ABR, and you're going to have your PQRST. Fever, thyroid problems, stuff like that will cause it. Okay, now we're going to go into SVT, supraventricular tachycardia. We have two main versions of SVT that we talk about. We have something called AV-NRT, okay, which is AV nodal re-entry tachycardia. Nodal meaning at the AV node is where the problem is. Okay, this is going to be the most common cause of SVT. Rates are going to be a little bit higher in these SVTs, 150 to 250 or so. And typically, when we think about SVT, we think about affecting the younger population. Now, can you see it in people that are 60 and 70? You absolutely can, but oftentimes this affects the younger population. Sometimes this is due to an excessive use of caffeine. Sometimes people have increased sympathetic tone, that fight or flight. Sometimes exercise can push these patients into this supraventricular tachycardia, SVT. The way that AV-NRT works is that we still have a depolarization that starts from the SA node. It's coming down and it goes towards the AV node, goes over to the left atrium, no problem. The problem is at the AV node. At the AV node, we have this re-entrant circuit. We have a re-entrant circuit. There's something wrong with the AV node, and a lot of these patients are actually born with this, but some of them can develop. They get some sort of scarring that occurs at the AV node. And when you get that scarring, it allows sometimes for the AV node to work appropriately, where we have that, that slight delay. But then the other part of that AV node is a really fast depolarization that's occurring. So you get this depolarization, goes from the SA node down to the AV node. Okay, so some of those depolarizations will go down normally to the ventricles, but then it comes right back around and goes right back down to the ventricles, right back around and right back down to the ventricles. So we have this super fast rate because we essentially, when we look at the AV node, we have this like electrical chaos going on at the AV node. And it's causing that increase in heart rate. So what we will see on our ECG, we're going to see that narrow complex tachycardia. We're going to see those higher rates, okay? And most of the time, you're not going to see a P wave with these. And that's what helps you determine, is this sinus tachycardia or is this an SVT? Because with sinus tachycardia, I should be seeing P waves, right? With SVT, most of the time you're not seeing P waves. The P waves oftentimes are actually into the QRS complex because the rate is so fast, we're not able to see those P waves. Now this rate on this ECG is not all that fast. It's about 144. Okay? And this is why I don't want you to memorize those rates, because you can have SVT with a little bit lower rate, or this could be 250 with the SVT. Okay? But this, we see, look at this bottom, and we can see it looks regular. We are narrow, but we don't really see P waves. We have T waves, but we do not see P waves before our QRS complexes. Oftentimes, these patients will come in and they will say, I had a sudden onset of these palpitations. We'll feel their heart rate, it's regular, but super fast. We get the ECG, and this is what the ECG gives us. So most of the time, these patients, it was a sudden onset. And again, it could be caused by something like exercise, or they could have just been sitting there. You will see this not infrequently in the active duty population. Okay? These patients come in all the time with this SVT. And most of the time, it is due to some sort of consumption. Okay? Oftentimes, energy drinks. Okay, these guys are drinking energy drinks nonstop, deployments or in the field. They're always drinking these energy drinks, which is going to increase their heart rate anyway, and it's going to push them into something like an SVT. Okay, another form of SVT is AV reentrant tachycardia. So this does not have the nodal portion, it is not the AV node. This is actually associated with some sort of accessory pathway in the heart between the atria and the ventricles. Most commonly, it's something called Wolff-Parkinson-White. Okay? And again, most of the time, these patients are born with this accessory pathway. We just don't know that they have it until they start having these episodes of severe tachycardia. The rate still is about 150 to 250 because it is an SVT. Okay? Oftentimes, again, still affects younger folks. And what happens is we still have that SA node that's firing, and it depolarizes down to the AV node, comes down to the upper portion of the ventricles, but then goes right back up through that accessory pathway. So the accessory pathway is like a super highway for depolarization. It's an opening between the atria and the ventricles. And we're having this big depolarization down here, but as it comes right back up, it goes right back through the AV node. So the rate is 150 to 250 only because the AV node is still trying to block a bunch of those depolarizations from coming down. If you started with an atrial, from the SA node, if you started with a really fast rate that's coming down from the SA node or from the atria, and the atria were firing all of us, you could have atrial rates of the 300 or 400s. Okay? But most of the time, the AV node is going to be able to block those from coming down. So we'll only see maybe rates of 200 because of the AV node. So with these patients, they have this accessory pathway, but the AV node is still blocking some of that depolarization, but we still have that higher rate of heart rate, at 150 to 250. And it's all because of this accessory pathway. And that accessory pathway could be on the right side, or it could be on the left side, but the signs and symptoms are still the same. Most commonly with this ADRT, it's going to be called orthodromic. Okay? Orthodromic means it's coming from the SA node down to the AV node, getting down to the ventricles, but it's going to shoot right back up through the AV node. If this is antidromic, that's where you run into the real problem. Antidromic is this: SA node right straight down to the ventricles. So again, not a big deal if your heart rate's 60, 70, 80, 90. Huge deal if your heart rate's 200, because every one of those are going right down to the ventricles. Okay? Huge deal if your heart rate's 300, maybe something like an atrial fibrillation or atrial flutter, because it's going right down to the ventricles. Okay? So most commonly orthodromic, and this would be an orthodromic AVRT EKG. Again, super fast. It's actually about 220 beats per minute, and really no clear P waves. And most commonly no clear P waves because they're hidden in evidence. The rate is so fast. And we can determine that this is not a sinus tachycardia because one, the rate's a little bit faster sinus tachycardia, and two, we have no indication by seeing those P waves. So what you guys remember, I think maybe the second lecture, I said that if you have a really, really fast heart rate, is there a way that we can slow this down? Is there a way that we can do something to slow this down so we can identify, do I actually have P waves or no?
Box breathing, you said.
What did you say?
The box breathing, whatever.
So yeah, we can do something to the EKG machine, right? So our normal rate, our normal millimeters per second is 25 millimeters per second where pen is on paper, right? We can go into the EKG machine and we can change this to something like a 50 millimeters per second, and that will slow this down. And we do that all the time in the emergency department because these patients come in, and before we give them medication, we're like, wait, let's confirm. Is this actually a sinus tachycardia that's much faster than we would think? Or is this an SVT? Because the treatment is going to be different from sinus tachycardia and SVT. So if you're in a position, you're like, I really don't know, patient looks okay, I've got a little bit of time, we can slow that EKG down and try to identify, is this in fact a regular narrow complex, okay? Do I see P waves, okay, or not? And that's gonna help us determine what the management is for these patients. And we don't talk about management in EKG, because I just need you to recognize these rhythms. And you'll talk about management in cardiology. Here's the problem. Here's the problem. Now, there are some of you that are really good at EKGs already. Some of you can determine, is this AVNRT or AVRT? I would bet that even those people that think they can determine the difference can't, because there's not really a difference. There's not really a difference. On ECG, between AVNRT and AVRT, the ECG is going to look very similar. Your history is going to be important in these patients, but the treatment is the same. So there are versions of SVT, okay, and they're caused by different cardiac anomalies, but the treatment is still the same in these patients. So I'm not going to give you on the exam an ECG and say, is this AVNRT or is this AVRT? I'm not going to give you that. Is this sinus tachycardia or is this SVT? Yes, yes, but not the difference between AVNRT and AVRT. Because most of the time you can't tell, and it doesn't really matter the treatment is. All right, another narrow complex regular tachycardia is atrial flutter with a non-variable block. Atrial flutter, in atrial flutter, we have a single foci in the atria that is just firing like crazy. Okay? It is firing 200 to 350 atrial beats. Atrial beats. And because it's going so fast, but it's not really all that affected, we're not going to see really clear P waves. We're going to see what we call flutter waves, which is why atrial flutter. We're going to see flutter waves because that's what the atria are doing from this single part of the atria that is firing. So this is not really coming from the SA node, it's coming down from somewhere in the atria where we have a sensitive area in the atria, that's a foci in the atria that's firing super, super fast. 250 to 350, again with those atrial waves. And most of the time we're going to see this in older people that have comorbidities. Heart failure, maybe they have prior history of MI, maybe they have valvular disorder, something like COPD, and they're having a bad COPD exacerbation, that affects the lungs. Well, ultimately the lungs are going to affect the heart. Number one cause of cardiac arrest is respiratory arrest, right? So we can see this in those type of patients. Another issue that we see that is a complication associated not with just atrial flutter, but atrial fibrillation as well, is stroke. Because the atria, again, they're just kind of fluttering along, which means that we're having a backflow or an excessive amount of fluid, of blood, that kind of is hanging out in the atria, and that's going to start clotting. And once that ventricular depolarization does come through, again, it can push those clots down and then through the systemic vasculature, which increases these patients' risk for not only stroke, but things like pulmonary embolism. But what we're seeing on this snapshot here is we see occasionally a QRS complex. QRS. But in between there, we see these looks like flutter waves. So it would be hard to determine, like, how am I having all these waves? Is it a P? Is it a U? Is it a T wave? What's going on? When you see something like that where you can't really figure it out, those are our flutter waves. And occasionally we have a depolarization all the way down to the ventricles, which is our QRS complex. Again, the AV node is doing its job. The AV node has a longer refractory period to allow the difference between the atria contracting and the ventricles contracting. So the AV node is blocking the majority of those atrial depolarizations that are coming through. It's only allowing so many to come through. Sometimes, when we have a non-variable block, it's allowing so many to come through at a regular rate. Sometimes it allows those depolarizations to come through at irregular rates. Okay? But for this, we're talking about regular rate, so it's a narrow complex regular tachycardia, okay? But the problem is when you look at your R waves, your ventricular rate is not going to be elevated in the majority of these patients. It's the atrial rate that makes us the tachycardia. I mean, when you feel the person's pulse, okay, can you feel the atria contracting when you feel the person's pulse? No, it's the ventricles contracting. So you're like, well, we got rate 60, 70. Why is this person weak and dizzy then? Why are they lightheaded? I better get that EKG. You get that EKG, you're like, oh, this is the reason why. The ventricular rate's okay, but the atria is doing this, and that's the problem. So we have this classic, what they say is sawtooth pattern. The sawtooth pattern, because it looks like a sawtooth when we look at these flutter waves. Most commonly, when we look at these flutter waves, or you can see them more prominently in leads 2, 3, and AVF, and then oftentimes in V1. So when we look at this, we look at lead 1. Well, lead 1, we definitely have our QRS complexes, and they look pretty regular, but we see stuff in between here, and it's like, well, I don't know, maybe that's a T wave here, maybe it got a P, like I don't really know what that is. And so that wouldn't really tell you that this is atrial flutter. But now come down and look at lead 3. Look at lead AVF, and look at these waves that are coming in between there. So that's why we don't just look at one lead. We've got to look at all the leads, because there are certain leads that are going to tell us more about this rhythm than other leads. Look over at V1. V1 has great flutter waves that are coming up through here. Just like, looks like you're in the ocean, like waves. And same thing down here. This is our V1 down here. Remember that 10-second strip? I told you most of the time it's going to be lead 2. Well, this one happens to be V1. It's still a 10-second strip that has pulled that V1 down. And it's really to show you and highlight how you can see these flutter waves that are coming through. So on this one, we don't have a really high ventricular rate. We have a higher atrial rate, which again makes that your tachycardia. This is atrial flutter. And this is a 3-to-1 block atrial flutter. Meaning for every 3 atrial beats we have one that gets all the way down for depolarization of the ventricles. And how do we know this is a 3-to-1 atrial block? We count our flutter waves. 1, 2, 3. And then we have depolarization of the ventricle. 1, 2, 3, depolarization of ventricles. So it's a regular block. For every 3 flutter waves, we get 1 depolarization, and that's just how it's working out for this specific EKG for this specific patient. The really confusing one is, and what we see more often is when you have a 1-to-1 block. 1 atria depolarization, 1 atrial flutter, and then 1 ventricular. 1 atria, 1 ventricular. And those are kind of the trickier ones. But this is a 3-to-1, and by looking at this, again, you could think about, well, this is my T, this is my P, but if you have something that's coming up like this, and you have another beat in between there, certainly this patient may need some labs, but these are what we call our flutter waves. Okay. So tachy, narrow, and regular, we have sinus tachycardia, we have SVT, and we have atrial flutter with a non-variable block. Now we have tachycardia, narrow, and irregular. Irregular rates. So narrow complex QRS, meaning less than 3 boxes, or 0.12 seconds. That's narrow. Atrial fibrillation, which is going to be most common, multifocal atrial tachycardia, and that atrial flutter is back, but now we have a variable block. Atrial fibrillation affects 2 million people worldwide. I mean, it's the most common cause of atrial arrhythmias in the world. So you are going to see this. I have seen it in young, and I have seen it in old. But the majority of the time, it's going to be older population that have comorbidities. Hypertension, higher MI, they have known coronary artery disease. Okay, again, thyroid disorders. stressed. I have seen young people that had undiagnosed thyroid problems that put them into atrial fibrillation, and then ultimately they got their thyroid problem diagnosed because of the atrial fibrillation. People with sleep apnea are more prone to atrial fibrillation, and of course those with valvular disorders increases their risk. Our rate is pretty fast with this. Our atrial rate, again, 350 to 450, atrial rate. Ventricular rate is going to vary. Sometimes, especially people that have a history of atrial fibrillation, they're on medication, they can be in chronic AFib, but their ventricular rate is going to be 60 or 70 because they're on medication to control the depolarizations going down to the ventricle. Because when you have those really high ventricular rates, that's when those patients become a lot more symptomatic. When we think about atrial fibrillation, now we have multiple areas, multiple foci in the atria that are firing all at once. They're just all firing. So totally erratic firing of the atria is occurring. And our atria are doing this because of all this misfiring of those electrical foci. So the atria are depolarizing all over the place, but not really effective depolarization. Okay? And because it's not effective depolarization, we're going to have only a certain number of depolarizations that get all the way down to the ventricles. Sometimes they can be higher, sometimes they can be a lower for heart rate. So these patients often will be symptomatic depending on what their ventricular rate is. Okay, so you have that palpitations, that weakness, dizziness. A lot of these patients have a history of AFib, know exactly when they go into atrial fibrillation because they'll start feeling their heart is beating differently. They feel that irregularity of their heart rate. Just like we saw with atrial flutter, because the atria are really just fibrillating, we don't have effective blood flow. The blood is going to be stagnant into the atria, that increases our risk of it clotting, and then ultimately when that blood gets down to the ventricles and out through the body, they can be associated with clots, and those clots will go into the systemic vasculature, increasing their risk for stroke and pulmonary embolism as well. On our ECG, we're going to see clearly some QRS complexes, okay, but in between there, we're going to see just a whole bunch of, I don't know, when you think about your 2-year-old writing you a letter, right? A whole bunch of this. Okay? At least my 2-year-old. Almost my 16-year-old too. And I'm like, what is this? What are you even writing here, right? You know, your teachers have to be able to read this. But you don't really see anything. There's a whole bunch of lines in there. And then you will have a depolarization at the ventricles. But look, irregular conduction of that depolarization from the atrial foci down to the ventricles. And not only is it irregular, but it's irregularly irregular. Okay? And that's what we commonly say about atrial fibrillation. It's irregularly irregular. It makes no sense to me on how these depolarizations are occurring. Okay? Here we have depolarization that are occurring, but this one's way far apart. This is closer, this is closer, this is even closer than that. This one's far apart. So there's no rhyme or reason to when these depolarizations are going to get through the AV node and down to the ventricles. This bottom area, this is a strip of a normal. So we've got PQRST, which means obviously CRP waves. We look at this top strip, again, we see a bunch of stuff in between here, but nothing is clearly a P wave that is occurring just before the QRS complex. They're actually, this is a P wave, and this is a P wave. So the P waves are in there, right? But they're not clearly identified. So if you don't have clear P waves and you have this irregular narrow complex tachycardia, that is atrial fibrillation. This is an example of atrial fibrillation. And we call this atrial fibrillation with rapid ventricular response, which is what puts these patients into this tachycardia as well. So the rapid ventricular response, meaning our ventricular rate is greater than 100. Okay, oftentimes these guys will come in with ventricular rates in the 130s, 140s, 150s, 160s. And as you're looking at the monitor, these patients have, significant changes in their heart rate. It'll be 160, down to 120, then to 130, then 180, then down to 140. So their ventricular rate's all over the place, which is again an indication that this is atrial fibrillation. Now the irregular conduction of depolarization down to the ventricle. When we look at our bottom strip here, we can tell that this looks to be a little tachycardic. If we counted this, it would tell us our tachycardia. And then we look at our R to R. And the R to R said, okay, I've got a tachycardic rate. It's irregular. What about my P waves? Am I seeing P waves in here? Well, I see a T wave, it looks like here. There's something here, but I don't really see any clear. Maybe this is a P, maybe it's a T. I don't really see any clear P waves looking across my strip here. And again, if you look at all the different leads, there are some leads that are going to show this atrial fibrillation better than others. If you look up here in lead one, you don't really see much at all. So that's not really all that helpful. Okay, but if you look down here in lead 3, lead AF a little bit, over here in V1, just like we saw with atrial flutter, that's where you're going to see the difference. You're going to see those fibrillatory waves in between your QRS complexes and depolarization. Here's another atrial fibrillation with rapid ventricular response. So we look at this bottom strip and say that's a pretty fast rate. Okay? We know it's narrow complex. We see it's irregular. Okay, now let me figure out, do I see a bunch of P waves in here? Or do I see P waves that are specifically associated with my QRS complex? It looks like I have a T wave here, but I don't really see any clear P waves in here. Okay? I come up here and I also don't see any flutter waves in here. I just see a bunch of stuff in between my QRS complexes. So irregular, I don't see flutter waves, I don't see clear P waves, atrial fibrillation. Multifocal atrial tachycardia. Right? Very similar to atrial fibrillation in that we have more than one foci in the atria that are depolarizing, okay, but the rate doesn't typically seem to be as high. It's still going to be irregular, and it's still going to be a tachycardia, and it's still going to be narrow, but our rate is going to be not as high as we're going to see in the AFib. And the etiology is different from multifocal atrial tachycardia. Think about severe pulmonary disease, uncontrolled COPD. Maybe this person comes in and they have multifocal pneumonia, hypoxic, tachycardia. Those patients can push them into multifocal atrial tachycardia. People that have poorly controlled CHF, or they're having a CHF exacerbation, can be pushed into multifocal atrial tachycardia. And they can go in and out of multifocal atrial tachycardia. And then electrolyte derangements can also cause these patients, like hypo-K or hypo-MAG, can cause patients to go into multifocal atrial tachycardia. What will you see on your ECG? Okay? Because we have 3 or more foci of the atria that are depolarizing, you're going to see 3 or more different morphologies of your P waves. So as you're looking at your P waves, if you have one foci that is depolarizing, your P waves should look the same. Every time you have different foci that are depolarizing, it's going to change how your P waves look. For this, we have 3 or more different foci, so your P waves, you're going to have 3 or more different morphology P waves that are going to be irregular in your rhythm, so your R to R is going to be irregular, narrow complex, and then you're going to see P waves, but they're going to look different. So at the bottom, we can definitely tell this is a narrow complex. Okay? This is a tachycardic rate. Okay? This is irregular. So if I say, okay, I've got irregular, narrow complex, tachycardia, I've got to look at my differentials. We talked about atrial fibrillation. Okay? But look at our P waves. So this first one, this is actually a P wave, but it's inverted. It's going down. Anybody have any idea what causes an inverted P wave? maybe what you're thinking, retrograde depolarization. So in other words, we have depolarization that comes down, okay, but then we'll have some depolarization that comes back up to the atria, and it causes those atria to depolarize, but it's going to be inverted on our ECG. So we see an inverted P wave here, and how do we know it's a P? Well, it's a little bit hard maybe, but we have a QRS complex right after it, and then we have a T wave, so that's your indication that's probably a P. We don't really see much of a P wave here. We see a P wave here where it's upright, so that's one different kind of P wave. We come all the way over here, we see a P wave that's upright. It's a little bit different. This one's more flat. We got a P wave here. Okay, we come all over here, we got another inverted P wave. This one we don't really see much. So we just have these P waves that are different morphology. They don't look the same. It tells you they're coming from different foci in the atria. Again, for this, I want you to really focus on what is their underlying pathology. Yes, sir?
I don't quite understand what you say about different foci. I don't quite understand what you say different foci.
Oh, okay. So, look at this picture on the top. Okay. So we have our SA node, and then we have these four different little round areas, little spiculated areas. So what that means is in the atria, okay, the SA node is either firing or not firing appropriately, so the atria is taking over. But not just one part of the atria, multiple areas in the atria are firing at the same time. Okay? The atria are very irritated. And so when the atria get very irritated, we have one area that fires, but this area is firing, this area is firing, this area is firing. So all of that is occurring at the same time. And they're all trying to send depolarizations down to the ventricles. Okay, does that make sense? So instead of one area in the atria taking over, the entire atria has gone chaotic. They're like, I don't know. We don't really know what's going on, so we're just all going to fire. And this here is saying that there are 3 or more different areas in the atria that are firing at the same time. Again, underlying pathophysiology, underlying diagnosis, something severe respiratory, pulmonary hypertension, uncontrolled COPD, bad pneumonia, they're hypoxic, something to do with the lungs that is now affecting the heart. Okay, and then we're back to atrial flutter, only now, right, instead of having this consistent depolarization, maybe every 2 waves, maybe every 3 waves, okay, now it's variable. Okay, we still have those flutter waves, but now we're going to have a narrow, complex, irregular tachycardia because we're having variable blocks. So sometimes the AV node will let every other beat, sometimes it's every second beat, sometimes it's every third, and it's all pushed into one ECG. So when you look at that bottom 10-second rhythm strip, it's going to look irregular, but then you look at 2, 3 in AVF and you're like, yeah, but I see flutter waves in there. Look at 1, I see flutter waves. We have a variable block atrial flutter. Okay. Here's an example of a rhythm strip with a variable block atrial flutter. And again, we have 2-to-1 block. 2-to-1 block is really hard to identify, 2-to-1 block. I will tell you the key for 2-to-1 block, you have someone coming in and they have a heart rate of 150, 150, 150, and it never moves from 150, that's a 2-to-1 block. Every day of the week, that's a 2-to-1 block for atrial flutter. Okay. But otherwise, we have, so here we have 1, 2, and we have our QRS complex. Look at this, 1, 2, 3, 4. So this is a 4-to-1 block. And then a 1, 2, 2-to-1, 1, 2, 3, 3-to-1 block. And all of that can be intermixed, and you will see that under 10-second rhythm strip at the bottom. So atrial flutter with a variable block, you're still going to have flutter waves. Okay? You're going to still have flutter waves, but it's going to be variable in the depolarization all the way down to the ventricles. If we look up here in lead 3 looks like a whole bunch of flutter waves. Okay? We don't even see much QRS, a tiny QRS here. If we look over here in V1, flutter wave, flutter wave, flutter wave, and then a depolarization. If we look down here at our bottom rhythm strip, again, we see flutter wave, flutter wave, flutter wave. So that's 3-to-1. Here's 1, 2, 3-to-1. Now we have 2-to-1. Then we go back to a 3-to-1. So variable block, meaning the amount of depolarizations getting through the AV node is variable. It's differing from beat to beat to beat to beat. All right, let's take a break. We officially became, 1776, we officially became the United States of America. Because prior to that we were called, anyone else? The United Colonies. United Colonies. In 1860, Sally Tompkins. So Sally Tompkins was the first female that was inducted into the Confederate Army. She was a nurse. And her story is actually kind of interesting. So in her town in Virginia, the judge took his family away because the armies were coming in, big fights. So he's like, we're going somewhere safe. And he said, but you can use my, I guess apparently had a pretty decent sized house. You can use my home if you need to, because she was trying to care for a wounded service member and soldier. And so she used his home and opened herself up his home. And then ultimately they incorporated her as the first female of the home. So she took care of a lot of wounded soldiers and ultimately opened up a hospital with her own money to continue to care for these wounded soldiers. And then this is really cool. Anybody hear about this guy who's actually in the military? Aaron James. Anybody know about Aaron James and the face transplant? So he was in the military, really bad electrical injury, and pretty much just blew up his face. Okay? And so in New York hospital, Langone Health, this was the first considered successful whole face and eye transplant. So he lost his eye, he blew his eye out, his whole face was all deformed. You guys can look up a picture. But they don't really consider it successful until it's been after a year after, and it was a year after, so they said, no, technically it is successful. So the first one. The last I read on him is he could, for a long time, he couldn't see anything out of his transplanted eye. His pressures were all normal. They couldn't really identify why he couldn't see, but the last I read about him, he was able to see like large things. Like you could see if your hand was waving, you can't see small things like that. So still pretty significant feat in medical history for a face transplant. And I remember meeting, maybe I was out in Fort Bragg, but I remember the doctor that did this, she came to Fort Bragg and spoke to us, and her goal, this was back in the early 2000s. Okay? Yes, I know. But she came and spoke to us, and she said that was her ultimate goal, and she was not part of the military, but her ultimate goal was to help service members that had significant injuries, and that was one of her top things was just to do something like this, like a face transplant, because they had been done previously, but were never successful. And so this was the same doctor that was able to do successful face transplant. So pretty cool. All right. So we talked about tachycardia, narrow and regular. Narrow and regular, sinus tachycardia, SVT, and atrial flutter with a non-variable block. Narrow and irregular, atrial fibrillation, multifocal atrial tachycardia, which is most commonly going to be seen in somebody with severe respiratory something, okay, and then atrial flutter, so still fluttering, but with a variable block, Okay, so now that's our narrow complex. If you're looking at the bottom, you see a narrow complex, it's tachycardia, figure out if it's regular or irregular, and those are your differentials. Tachycardia, and now we have wide and regular. So again, QRS complex is wide, greater than 3 small boxes, greater than 0.12 seconds. Okay, 3 small boxes. We have VTAC, we have V-flutter, ventricular flutter, or we have SVT with a bundle branch block. Anything that has a bundle branch block in and of itself causes a wide QRS complex. So if you have SVT, you're going to have a fast rate, and it's going to be wide because they have a bundle branch block. And we have a specific lecture on bundle branch blocks, so we're not going to focus on that today, but anytime we have a bundle branch block, it's going to cause a wide complex QRS. So ventricular tachycardia. Oftentimes, these patients are going to come in, and either they felt like they're going to pass out, or maybe they did pass out. And usually they'll have like this sudden onset, paroxysmal, sudden onset of pretty significant palpitation. Because now we're talking about the ventricles are, really beating very, very quickly. Not atrial. Okay, atria, when they beat, we don't really feel that much. When those ventricles are beating fast, those patients are going to be symptomatic. They're going to know that their heart rate is really beating fast. Okay? And most of the time, what you're going to see this QRS complex. It's going to be wide. It's going to be kind of, in your face, like, man, what's going on with that QRS complex? Why is it so obnoxious? Why is it so wide? But we're going to have regular R to R intervals. The regular R to R intervals. You can actually have P waves. Okay? The atria oftentimes are still depolarizing, but we don't see the P waves, or at least not clearly, before that QRS complex. Because the QRS complex is so wide, it buries the P wave within the QRS complex. For example, and I'm not going to have you guys do any of this on the, I'm not going to ask you like, where is the P wave in this QRS complex? I just want to point out to you that in fact there is some P wave. If we look here, this is actually a P wave on the upstroke of this wide QRS. Okay, we have a P wave here. This one has a P wave all the way on top. Okay, so there are P waves that are buried in the atria, still depolarizing. The problem down here is the ventricles. And when we have ventricular tachycardia, we have an area in the ventricles that is foci in the ventricles that is depolarizing much too quickly. Okay, so it's outside of our electrical conduction pathway usually, and we have that one area, that foci, that is just constantly depolarizing the ventricles, which is causing this super fast rate. And usually 150 to 250 with these patients. A lot of different causes of ventricular tachycardia. Again, myocardial infarction. Okay, if they have known coronary artery disease, valvular disease, ventricular hypertrophy can cause irritable foci in the ventricles as well. Electrical derangement, certainly not uncommon to cause these patients to go into ventricular tachycardia. Even something like hypoxia. Hypoxia can cause patients to go into ventricular tachycardia. So we think about low potassium. Oftentimes if you have low potassium, you also have low mag. So those are electrolyte derangements. This is what VTAC looks like. This is what VTAC looks like. Sometimes you will have a couple of normal beats on here, and then you'll see these patients go into VTAC. And then sometimes, if you're super lucky, they go back into a normal beat. And you're like, oh, thank God. Okay? Because VTAC can turn out bad. I remember working a shift at BMC with this old crusty SF nurse, Ron. And we get this patient that came in from Lackland, and he was like a 50-some-year-old dude, and he had palpitations, felt like he was going to pass out. And we get him into the bed, and we look up at the monitor, and Ron's like, Sue, do you see that? Do you see that? I'm like, I have eyes too, Ron. I can see. And the guy's going into VTAC. Right? I'm like, well, what are you going to do, Ron? Give him some medicine. Give him some medicine. Back then we get amnio. So, things change as far as medication. But put him on it, give him some amnio, put him on amnio, get up, and the guy gets back. And then we call cardiology and say, hey, this guy is going in and out of VTAC. Well, how long was he in VTAC? I don't know, a minute or so. Is it sustained? Well, it was a minute of VTAC, so that, is technically considered sustained. Is he in VTAC now? No. We can follow up because that's an outpatient. Whew. No, I don't think he can. No. I think this guy's got to come in. He needs to come in because this is the first time ever going into VTAC. He needs a workout, right? But you will get pushback, not so much for Reserve and National Guard folks, not so much, because those guys on the outside get paid, right? They get paid pretty good. In the military, a major is a major is a major. Right? Although although cardiology people do get an extra stipend, right? They get extra money, but they act like they don't. So they don't want to see these patients. We'll just see them later. So sometimes you gotta be like, no, I think you're gonna have to see them now, or you're gonna have to come and sign this note that says this patient can go home. So these guys can go in and out of VTAC, but it's still gonna look the same. It's a wide complex tachycardia. Some of you guys may say, well, how do I know what the rate is here? Do I count from up here? Do I count from down here? Does it matter? It doesn't really matter, because you're going to come up with pretty much the same number. But I still, I typically would just come from the top, and I just count my R waves across, and I put a mark here, and I put a mark here, and I take my paper and make sure that everything marches out. So this should be a regular, wide, complex tachycardia. But when you see this, there's not a tremendous amount of time to go through and read a whole bunch of other things on this ECG. First of all, you're not going to find a bunch of other things on this ECG. These patients need to be managed fairly quickly. Okay? They tend to do with VTAC, they tend to do okay. But we're going to notice this wide complex tachycardia and say, okay, you're in VTAC, let's go ahead and do something about this VTAC. Let's slow us right down, okay, and get you back into hopefully a normal Alzheimer's range. And so that's VTAC. So these patients can come in certainly talking. They could walk in to the clinic with VTAC, and then you do that ECG and you'll identify them. V-flutter, we think about this as an extreme form of VTAC. Much faster rates at 250 to 350 ventricular rates, so that's a super fast rate. These patients are oftentimes, if they aren't being brought in by EMS unresponsive, they're very soon to be unresponsive. Because if you have a ventricular rate of 350, you're not getting very good systemic push of blood, right? So that blood is not getting out because you don't have a really good depolarization, really good contraction that is going to push all that blood out, because they're contracting, the ventricles are contracting so fast that we're not getting blood to the heart, to the lungs, and to the brain. Okay? This is really fast. Extreme form of VTAC. Instead of us looking here at VTAC, we're like, okay, if I could look at the rate, and I say, this kind of falls on there, say 300, 150 or so. Here, this is every other. Okay, so super fast. Extreme form of VTAC. And oftentimes, this person is having an MI or had a recent MI, some sort of electrolyte derangement is causing this. They could have cardiomyopathy, cocaine. So, of all the drugs I tell people to do, heroin's probably not great for you, that's probably not so good, but cocaine is really bad. Cocaine immediately affects the heart, and these can put these patients in the flutter, the TAC, third degree heart block, all of the bad things associated with cocaine. So cocaine and a little bit of meth. And then of course, what do people normally do? They take them together, of course, because that's what you're supposed to do. So then we really set them up for cardiac anomalies. So VTAC, okay, we have that on the top. So yeah, it looks ugly, but we can see our rate, okay, not quite enough. V-flutter, unresponsive or very soon to be, within a minute or so, okay, and much faster ventricular rate. Okay. SVT, so we have still wide complex. Okay, we still have this rate of 250 to 350, but this is really associated with SVT. Now, when we look at this, here's an SVT, bundle branch block. We have that rate of 150 to 250. Okay, these patients are often, because it's SVT, they may still be in that younger population, but because usually this is associated with a bundle branch block for this, they're going to be in that maybe 40s, 50 to 60, because something's causing that bundle branch block to occur. Usually some sort of underlying cardiac disease. So on our EKG, we can just see this wide, complex tachycardia, not as wide as we're going to see with that VTAC, okay? But still a wide, complex, and still a fast rate. When we think about VFib, we think about SVT with bundle branch block. We think about VTAC. What you guys will learn in cardiology, according to the ACLS algorithm, is that they're all treated the same. Because if you go back to this, okay, again, some of you are really good at reading EKGs, but if you go back to this, and I did not point all of this out and had no labels on them, you may say, God, they look pretty darn similar. But yeah, that one's a little bit faster, but how do I tell the difference between those? The management is essentially the same. Okay? Well, V-flutter, the presentation is going to be a little bit different. Most of the time, these guys are going to be unresponsive. So SVT with bundle branch block, VTAC, you're going to treat them as if this was VTAC, because VTAC's a lot more serious than SVT with bundle branch block. So we treat them as if it's VTAC. And again, Dr. DeBoer will talk about that for management purposes. So if we have wide and irregular, we have VFib, we have polymorphic VTAC, and we have torsades. Wide and regular, what do we have for wide and regular? VTAC, V-flutter, and SVT with bundle branch block. And we're looking down the wide and irregular, VFib, polymorphic VTAC, and torsades. Okay, VFib. In VFib, just like we talked about with atrial fibrillation, we have multiple foci in the ventricles that are trying to fire all at once. We have this really erratic appearance on our ECG, going back to our arterial, trying to write a note. We don't know what the heck's going on. We don't even really see anything clear. It looks like a whole bunch of squiggly lines that are on our ECG. These patients are going to be coming into you unresponsive, and we have 30 seconds to a minute, maybe a minute and a half to fix this, or they're going to die. Okay? So they're unresponsive, found down, oftentimes EMS maybe put paddles on them, and they maybe evaluated them. But if they are not close to a hospital or close to somebody that can treat this, they're going to come in dead. So this is fatal within minutes. And again, these patients have underlying cardiac disease. They're going to be older patients, probably prior MI, valvular disease. It certainly can cause electrolyte derangements. I have seen both VFib and VTAC for patients that are dialysis patients that have not been dialyzed in a week or two, and it usually pushes them into electrolyte derangements and they're coming in. Okay? And then the other thing that can cause this, where you guys may see it, because oftentimes you guys will not be seeing this older population, especially active duty folks, is electrical shock. Okay, someone that came in and they got shocked. Even though we might think it's a minor shock, certainly if they're coming in unresponsive, it's not minor, but in general, when patients come in and they've gotten shocked, you always want to make sure that you get an ECG on them to look for any arrhythmia, even if it seems like a minor shock. Okay? Pregnant patients, especially, pregnant patients must have an ECG. But this is what it looks like. It looks like a whole bunch of things are happening all at once. Okay? A whole bunch of these foci in the ventricles are firing, and it looks like just a completely erratic arrhythmia that's going on. We have something called coarse VFib, okay, where we have these lines that are going up and down, but not in a regular fashion like we might see with V-flutter or VTAC. Okay. Here it's just it comes up, it comes down. We assume that this is probably an R wave. We're not really sure what these waves are. Here's probably an R wave, but there's really nothing that makes any sense. And then oftentimes, when we go from coarse VFib, which means our waves are greater than 3 millimeters in small boxes, well, essentially, or eventually, we will go into a fine VFib, and then we will go into a flat line. So it starts off like, okay, what is this crazy rhythm? And then within 30 seconds or so, now we're in a fine, and then we're into a flat line. So the definition of coarse is greater than 3 millimeters. Fine is less than 3 millimeters in the amplitude of the waves that we're seeing. There's not a lot of ECGs out there for VFib. There's not a lot of ECGs out there for VFib. So this is one that I did find. And again, there's nothing here that tells us this is regular. This looks like, if for those of you who've done ECGs before, it looks like there's a lead or a couple of leads that are off of this patient. But we check the leads, the patient's unconscious, this is defib. There's nothing that we can really make any sense of, but it looks like something really bad is happening to this patient. Before we talk about our last two things that can cause wide, complex, irregular, we need to understand something called absolute and relative refractory period. So absolute refractory period begins at the beginning of our QRS complex and ends about the middle of our T wave. As our T wave goes up, and just before that downstroke of the T wave is our absolute refractory periods. During this time period, the heart is completely refractory to any additional stimuli. Okay? It is in between that depolarization, so we've got that depolarization. Okay? We cannot have any other stimuli that affects the heart that's going to cause a change in our depolarization from occurring. Okay? Meaning, someone gets hit in the chest really hard. That can affect the heart. That can affect the heart, and that can cause the heart to stop. It cannot, if that happens during this time period, and this absolute refractory period, the heart rate's not going to be affected. The heart rate is still going to function. It's going to go on to the T wave and through the repolarization, and we're going to have another depolarization, that absolute refractory period. In the relative refractory period, here's the problem. If something hard enough hits that heart, it can cause that heart to go into a fatal rhythm. Okay, so in the relative refractory period, we have partial repolarization of some of those myocardiocytes. The other of those myocardiocytes are beginning to depolarize. Okay? Well, they meet in the middle. When they meet in the middle, they don't know what to do, so we go into this very erratic, sometimes fatal arrhythmia. And if anybody, NFL fans, a little bit. Okay, so who was a couple years ago? Some guy, Bills maybe, got hit in the chest. Commotion cauda. Okay, he got hit. I can almost guarantee you during this relative refractory period, he got hit hard enough that his heart depolarization, repolarization met, and actually caused him to go into immediate. Probably not immediate, but by the time they got there, he was in cardiac arrest. Okay. If that had happened a half of a second, a quarter of a second earlier, it is very likely he would have been okay. You have to get hit at just the right time. So most of us don't run around getting hit in the chest, but what happens for us internally is you can have something called a premature ventricular contraction, where the ventricle, okay, we've got this normal depolarization, we've got our QRS complex, we're starting to do that repolarization, but the ventricle, the foci of the ventricle is that for some reason wants to depolarize. It depolarizes the ventricles. And it happens in that relative refractory period. So if it happens in that relative refractory period only for that last portion of the T wave, it can push these patients into these abnormal rhythms that can ultimately result in cardiac arrest. Okay? Now these are the rhythms we're going to talk about. They can push them into what we call an R on T phenomenon. So we've got the down portion of that T wave, or right at the top of that T wave as we're going down, and we end in that repolarization. Well, that premature ventricular contraction, that sudden hit, is going to cause the R wave to occur, that ventricular contraction to occur right at the end of our repolarization. And if that occurs, it's going to push these patients into something like a torsades or a weird ventricular tachycardia. And if that's not caught, sometimes the body can reset itself after several beats of this, and they'll go back into normal sinus rhythm. Sometimes they can't, especially if they have any sort of underlying cardiac anomalies. Okay, so this R on T phenomenon is that relative refractory, not the absolute refractory period. Okay? And again, I'm going to come back to this slide. Look at where this relative refractory period is. You see it? The latter portion of the T wave. you're going to have a question on it. You're going to have a question on it. I would know it's the lateral portion of the T-wave. Okay? 1, 2, 3, 4, or 5. It's going to be one of them numbers, but it's going to be the lateral portion of the T-wave. So you've got to know that, because that's where the problem is if you have a PVC. Not if you have a premature atria. If the atria contracts prematurely, the atria, they don't have enough electrical conduction to matter. But if the ventricles contract early, that's a big contraction. It's a big depolarization. And if that occurs in that relative refractory, it can push these patients into something like a polymorphic VTAC. So polymorphic VTAC is a type of ventricular tachycardia that can occur from something like an R-on-T phenomenon or something premature ventricular contraction occurring at the latter portion as of that T-wave or that relative refractory time period. Right? And we can differentiate this polymorphic VTAC from something like ventricular fibrillation by looking at the amplitude of our waves. By looking at the amplitude of our waves and polymorphic VTAC, a lot of times these patients are still conscious. They can still, they may be not feeling so good, but they're still conscious. And we can really make out, this is an R wave here, okay, we've got R wave here, our amplitude is much higher than we're going to see in our ventricular fibrillation. And on our ventricular fibrillation, those patients are going to be unconscious. Things that can cause polymorphic VTAC. People that have a heart attack, they can have. They have electrolyte burdens. They have hypertrophic cardiomyopathy. It can push them into polymorphic VTAC. Something called Brugada syndrome, which we'll talk about later, or even short QT, which is why it's important for you to understand what the QT interval should be. Short QT and then long QT can actually cause something called torsades. Torsades can be caused by R-on-T phenomenon, where they'll degenerate into this torsades. And torsades, again, people can go in and out of torsades, just like they can go in and out of polymorphic VTAC. But the biggest concern with polymorphic VTAC is that it can degenerate into a ventricular fibrillation. Where you have those long QRS complexes with high amplitude, they get lower, shorter, and shorter, and shorter, and go into VTAC. Okay. So torsades. We see this more commonly with patients that have a history of prolonged QT. And if you don't identify that history of prolonged T, and then you're like, oh, you're nauseous, I'm going to give you some ondansetron, and then we prolong that QT even more, we can push them into a torsade. People that have low potassium can go into a torsade. Or, again, myocardial disease can push them into a torsade. Oftentimes, these patients will have symptoms just like they have a tachycardia, palpitations, dizziness. Maybe they feel like their heart rate is off or irregular. Maybe they have syncopal episodes, and that's what prompts them to come in. What they call the classic, if there's a classic look for torsades, is this ribbon, a twisted ribbon appearance. And what it looks like is you have varying degrees of amplitude of your QRS complex. Yes, there are T waves in here, but they're in the wide QRS. So we have an amplitude of QRS that's a little bit higher here, and then it goes shorter, like in that area where the ribbon is twisted. And then it goes back higher amplitude, then shorter amplitude, and then higher amplitude, then shorter, like a twist. If we look at this ECG here, okay, you have a person that came in, and they're like, man, I was not really feeling all that well. I was having some palpitations. I felt like my heart rate was off. And we did our initial portion of the ECG. We've got our P, QRS, a T here, P, QRS, T. So that looks okay. But then we have P, QRS, P, and then we have a Q. And as we're coming up to baseline, and as that T is starting to form, we have the onset of this torsades. And we know it's torsades because we have this higher amplitude here, and then it goes to a lower amplitude. And then we have a higher amplitude here. So that's your indication that this is a torsades. This is an R-on-T phenomenon that then pushed this patient into a torsades deployment. Again, if this is sustained, certainly these patients can decompensate pretty quickly. Okay? And it is important for torsades to be able to identify torsades because the treatment is different than any of these other arrhythmias. The treatment for torsades, anybody know what the treatment for torsades is? Magnesium. So it's not, if you don't give them magnesium, they will degenerate into a fatal arrhythmia. So looking at the comparison between polymorphic VTAC and torsades, again, polymorphic VTAC, is kind of all over the place. Like we think with ventricular fibrillation, only the amplitude is much higher. And these patients oftentimes, although probably not feeling great, are still responsive to you. When we look at torsades, we have the changing in the amplitude, but it's more of a pattern changing. Lower, have higher amplitude, then lower, then higher amplitude, then lower, then higher amplitude, then lower. And think about somebody that maybe with electrolyte derangements, or they were put on a medication, or have a history of prolonged QT on a medication that can prolong their QT for those patients going into torsades. Okay, let me see here. Let's really see who knows if this is true or not. Code. Okay. Sir, what do you think? An apple a day? Does that keep the doctor away? Is that true or not true? You say true? You say not true? What'd you say? You say true. Anybody think it's true? It's true. How do you know these things? So there was actually a huge study out of Ohio State University. Yeah, well, Buckeyes, right? But they beat and this huge study, like 17,000 people, like it's a huge study. And they looked at their LDL and HDL before, putting on this kind of, that wasn't an apple diet, but they had an apple a day. And at the end of this study, they did in fact find that the LDL and HDL numbers were much better after this apple a day. So yes, in fact, it may not keep the doctor away, but it certainly promotes a healthier lifestyle and affects LDL and HDL, and which ultimately affects your cholesterol. So that is in fact true. What about Lesotho? Okay, ma'am. Going outside with your hair wet makes you sick. Do we go false? All right. Anybody think it's true? Your mama says it's true. Grandma says it's true. So you, in your mind, may say it ain't true. Oh, yes, mama. I know that's true. It's not true. It's not true. So we know that the common cold is caused by a virus. Well, viruses actually, people think that viruses love the heat, but viruses love the cold. Okay? So when we go outside and it's cold outside, okay, it's not because our hair is rubbing into viruses, it's because the viruses are more apt to be living in the cold. So that's really what it is. But we will never ever tell our parents that that's actually bless you. All right, we're going to do a couple of skills checks and then we'll finish up. Okay, Earl. Caden Earl. Okay, sir. Tell me, and we're going to focus on the stuff that we learned today. We're going to focus on the stuff we learned today. So when we're looking at this, when you're coming up with your differential, we're looking at that bottom rhythm strip. Bottom rhythm strip. What do you think about that? So what is your rate? You say it's a tachycardic rate because that's the point of today's lecture. Tachycardic. Okay, tachycardic. So what's the next thing you want to figure out? If it's regular or irregular. So what do you think? Okay, yeah, it definitely looks irregular. Okay, so so it's tachycardic, it's irregular. What's the next thing you want to know? Well, let's figure out if it's wide or narrow. Wide or narrow, because then that, so we have, so what do you think?
It's narrow.
So we have tachycardic, irregular, and narrow. What are our differentials for that?
Say that one more time, I'm sorry.
Okay, so we have tachycardic, right? Irregular and narrow. What would we say are our differentials for that type of tachycardia? So AFib, right? Multifocal atrial tachycardia, and A flutter with a variable block. Those are, we don't have to think about all the rest of that stuff. We don't even think about it. That's not part of our differential is irregular narrow complex tachycardia. So if I have on a question for you, VTAC, VFib, you're like, well, those aren't even narrow complex. I don't even have to worry about those. But if I have on here atrial flutter with a non-variable block, you're like, I don't have to worry about that either, because non-variable is not going to give me irregular. So when you're studying, you've got to put likes with likes. So you can automatically rule out some of these distractors on your answer. Okay, so based on that AFib, A flutter with variable block, or multifocal atrial tachycardia, what do you think this is? Multifocal atrial tachycardia. Because can we see P waves? We can see P waves. And the P, here you go, sir. And the P waves are different. Okay, the P waves are different. Look at this P wave compared to that P wave, compared to that one. This one and this one looks similar because that's probably coming from the same foci. But this is definitely different from that one. Okay, the foci is different because in multifocal atrial tachycardia we have 3 or more different foci, which means we have 3 or more different P waves. All right, very good, sir. Okay. Okay. No. Savage. Okay, sir. Okay. What do we, so we're looking at this, we're saying it's a tachycardic. Why? Okay, it looks regular, so we got a regular wide complex tachycardia. What would be our differentials? So VTAC, V flutter, and then SVT with a bunch block, right? So those are our 3. We forget about everything else because it's not narrow and it is regular. So what do you think this is, sir? Probably VTAC. Why is it not V flutter? Not fast enough. Not fast enough. V flutter. No. Fast. Every line is going to have something. Okay? The TAC is every line and a half. Okay? Much faster for VTAC. I mean, sorry, for V flutter, every line VTAC is, much slower for VTAC than not for V flutter. Okay, let's see here. Thompson? Okay, Thompson. All right. It's tachycardic. Okay. What else do we know about it?
Irregular.
It's irregular. So tachycardic, irregular. What else? Narrow. All right. Irregular, narrow complex tachycardia. What are our differentials? Matt? AFib? Nope. One more. A flutter with variable block. Variable block. And see those flutter waves, right? What do you think you got going on here? Why? Okay. Now, some of you may say, whoa, look up there at V1. Are those flutter waves? How do I know those aren't flutter waves? So, and even a little bit here, okay, you might say flutter waves. And sometimes that can be challenging. Sometimes that can be challenging. I will tell you that 9 times out of 10, it's going to be atrial fibrillation because that affects 2 million people. Okay? A flutter is not all that common. You don't see a lot of A flutter. Okay? And so if you have something like this, you're trying to determine, if I give you something, I want you to know it's A flutter, it will be very obviously A flutter. Okay? You will see the flutter wave. Okay? Something like this, okay, when you're looking at this and you look at that and say, are those flutter waves? Let's go down here. Okay? We don't really see, we see a couple of areas that might make you think flutter waves. Okay, it could be A flutter with a variable block. Okay? But if I also tell you that this person, well, the history is going to be the same. Just know, if I want you to know it's A flutter, it'll be obvious it's A flutter. So something like this, we don't see really good P waves in here. And we see really no flutter waves here, we see no P waves, and we don't see any P waves here, okay? But we just see some stuff in here, and sometimes, you know, it's really ragged. Okay? On this ECG, you don't see a ton of scribbly marks in between it. That's the nature of atrial fibrillation though. And sometimes atrial fibrillation, you look at the ECG, you're like, oh, that's totally atrial fibrillation. Other times, and on multiple occasions, not just with me, but the docs that I work with too, we're like, shoot, is this AFib? Is this AFib? Let's try to slow this down and see if we can see those fibrillatory waves, or see if we can see those flutter waves. So this is atrial fibrillation, okay? Now, Blasic. Okay, what do we see here, sir?
I see the saw teeth.
Okay, so narrow complex, wide complex?
Narrow.
Narrow, so narrow complex. We don't see a tachycardic ventricular rate, but we definitely see something in between those QRS complexes, right? So you, like you mentioned, we see sawtooth. Is it regular or irregular? Irregular. So we have irregular. And it's irregular because we have a flutter with a variable block. We have variable block A flutter. Do you guys see the difference between this and those flutter waves and this, where we don't really see clear flutter waves? Okay, that's sometimes. So flutter waves in real life, sometimes it's hard to determine. So we do different maneuvers to try to figure out what this is. Okay? But for testing purposes, we use different types. All right, so this is A flutter with variable block. Our other options would be atrial fibrillation or multifocal atrial tachycardia. We don't see clear P waves, so it's not multifocal atrial tachycardia. And we don't see fibrillatory waves. We see flutter waves in between these QRS complexes. All right, that's it.